what is going on. The routine data we have in the country is mostly DHIS2. And the DHIS2 in Uganda, but also DHIS2 in Uganda, but also in many countries, is improving. In fact, for many countries that we look at across Africa, Uganda currently has one of the best DHIS2 in terms of data quality. So you should clap for yourselves, Ugandans who are generating this. Now, this routine data has a lot of potential uses. Most importantly, it can guide programming, and especially at the subnational, to know how are things going, especially at this time when the government is trying to push for integrated health services. How do you know what is going on and whether services are going on as you need? But also you'll be able to know population coverage and it is cost effective. So the objective of this is to assess the use of routine data to see how RAMNAC services are improving or changing in Uganda, including immunization, and to look at the data quality, and also to see what are some of the areas for improvement, both in the data but also in the program. As I said, I work with a team. Most of them are the one who quench the data, so I'm going to invite Ronald, who is one of the analysts, to present what is the methodology that we use and some of the results. Then I'll come back at the end to wrap up. I just wanted to say, for those interested, after the end of this presentation, I'll have a copy of this report for about 100 people, so I should be able to share the report with you. Ronald.
Thank you. Thank you, Prof. Peter. Yeah, so when we get this routine data, we have a structured approach before we dig deeper into the analysis. So this aggregated monthly data, especially at district level, we perform quality assessment. And this includes checking for completeness in reporting, analyzing the consistency of the data, but also looking out for extreme outliers. So based on those three dimensions, we make relevant adjustments, and then we come up with a better data set. From that data set, we can now look at the raw reported values, depending on the indicator. From that, we are able to identify a better denominator that can give us estimates which are close to population level. So for service coverage, we know the numerator is always very straightforward, the population that has received the service. The most challenging problem is the denominator, where we look at the population that is actually in need of the service. In this case, which we call the target population. So, colleagues, allow me to take you a step-by-step assessment that we do for us to arrive to the correct or to a better denominator. So I'll give an example of DPT1 coverage. If we want to look at the denominator, which is the number of infants who are eligible for DPT1, we move from left going to the right. So from the left, we have the number of pregnancies, and these pregnancies can be estimated from ANC attendance. We get a proxy It's a proxy indicator because we know ANC1 is almost universal. So from the number of pregnancy, if we remove the pregnancy losses, we can actually get the number of deliveries. But also we know that some deliveries result into multiple births. So we also do some adjustments based on the outcome of the birth to come up with the total number of births. So from there, we remove stillbirths, and when we do that, we get the actual number of live births. So therefore, to get the number of infants who are eligible for DPT1 from the live births, we have to take off all the neonatal deaths. So if we want to go further to get the denominator that can be used to give us estimates for measles 1, we also have to take off the number of deaths that occur within the 1st to the 9th month. So that results. So we are seeing that generally completeness in reporting facility data has improved. And in the first row, we are seeing that by 2024, 97% of the facilities were actually reporting data directly to the DHIS2. But also, even when it comes to extreme outliers, the percentage of districts with extreme outliers has also improved. So by 2024, almost 90% of the districts had no extreme outliers. So generally, the overall annual data quality score for the data that is reported in the DHIS2 has improved from 2020 to 2024. So we also try to validate the findings we get from facility data with what we see in the surveys. And the surveys we compare with the UDHS, but also with the situation analysis for the newborn health. So this survey was conducted in 2023. So from facility data, the first bar, the blue, represents estimates from facility. The middle represents estimates from the UDHS, and then the green represents estimates from the CITAN. So we see that what we are getting from the facility data is almost close to what we are seeing from the surveys. So we go further to understand the trends. So using facility data, we can see that the population level ANC first trimester has increased by almost 7 percentage points from 2020 to 2024. But also we can visualize this and see the performance by region. These are population level estimates, but derived from facility data. For institutional delivery, it has also increased from 65% to 74% in 2024. And also we are seeing that we are seeing good performance in Ankole and Chigezi, but also even Bugisu and Bukedia. So we go further to illustrate the performance, the coverage of cesarean for the 2020 to 2024. So we are also seeing improvement, increase in cesarean section. By regional, we are seeing almost Kampala is the only region that is able to meet the WHO standard for cesarean section. So regions like Karamoja, Busoga are not really performing to the expectation. So we go further to understand the differences across regions. So this graph represents the inequalities in coverage. So each circle is a region. Across, that's the national estimate. So we are seeing that from 2020, the inequality in institutional delivery has narrowed. By 2024, almost all regions were had above. Some regions were able to achieve 100%, but also we are seeing there is a gap between the best performing and then the least performing region by almost 30 percentage points. Because you look at 60 and then the 90. So we go further to dig deeper into the child health. So for denominator still, here we illustrate Penta 3 and then measles. So the red line is the estimate from UDHS. Then each bar represents the coverage based on a particular denominator. So for the first graph on your left, we are seeing that Penta 1 gives us an estimate which is close to what we are seeing in the survey. Therefore, Penta 1 can be a better estimate for Penta 3. Same applies to measles. So we further try to understand the performance by region over time. So green indicates good performance. So when it comes to immunization, there has been progress across regions, with almost all regions having 80 and above coverage. The same story happens with measles. The population level coverage for measles 3 has also improved. We are seeing a lot of green. So that means that the country is doing a tremendous job when it comes to vaccination. So we can also further try to look at the inequalities. So much as all regions have achieved 80%, we are also seeing an increase in the gap between the best performing region and the least. So the inequality has somehow increased, and this is measured by what we call the median absolute deviation from the median. We abbreviate it as MADM. So it has increased from 6 to 7. So thank you very much. I want to invite Prof. Peter. Thank you.
So I think what we are trying to show you is that we can use our DHIS2 data as long as we improve it. If we do adjustment, we can have a good estimation of population level coverage and on a routine basis, even on a weekly basis. And there are so many other indicators we can measure. We just presented a few, just as an example, but we can measure all the maternal indicators, including actually mortality. Not really, we don't expect like within a 5% confidence interval like many scientists would want, but data that is relevant for program implementation. We can also do for child health in terms of birth weight, BCG, all the vaccines, but also mortality. We can also do on other indicators around system performance, like hospital performance, efficiency, all this capacity. We have within our unit at the School of Public Health using routine data. So to conclude, is that really our purpose is to show you that routine data, if improved, is a very powerful tool for knowing what is happening in programs. I know that the ministry does measurement this routinely, but I think what we are bringing as added value is methods for adjusting so that you're able to get a population level estimate. And you can estimate district coverage, but also national coverage, but also you can do equity analysis on the data. We have this capacity at the school. We've been training our students, but also would like to train district-level statisticians and to popularize this so that we are able to produce national reports. In fact, some years ago, we actually did evaluation of the sharpened plan using the same methodology. And I think it is the major report we have for the sharpened plan. Thank you for listening to us. I think the ask is we don't have the resources to continue doing this. We would like support. And we thank the ministry and the GFF and the partners who've been working with us, including APHRC, in coordinating and doing this work. Maybe one critical result which Ronald presented, since I have Professor Nachimuli here, is really the C-section, since we are into a maternal conference, which is showing that if you want to reduce maternal neonatal death, emergency obstetrical and newborn care must be available, but there are some regions that are really quite being left behind, and they should be prioritized. And if you prioritize them, even be prioritizing my village, because Busoga is one of those regions that is not doing well. Thank you so much. Yes. And as I said, we have some copies of the report, summary report, for about, I think, 100 participants. And those who want it, we can get it from the table.
Yes, thank you very much indeed, Professor. A round of applause, ladies and gentlemen, to Professor for that incredible presentation. In the interest of time, I would encourage for colleagues who may be having some, a bit of questions to the professor so that we can do the interactions during the lunch break. We will be now delving into our next critical session, and I'm very sure you will like it. We are going to look at triple elimination. And I would like to invite the moderator for this session, and who is none other than Dr. Linda Chisache. Dr. Linda Chisache. A little bit about Dr. Linda. Dr. Linda Chisache is a medical doctor, a public health specialist with over 15 years experience in working at different levels of the health sector. She has vast experience in supporting HIV programming, including HIV testing, care and treatment, and PMTCT. She previously supported scale-up of HTS services in private sector in Uganda and has worked as monitoring and evaluating officer for the HIV program at the Ministry of Health. She is presently coordinating the implementation of the PMTCT program at the Ministry of Health, Uganda. Ladies and gentlemen, our round of applause, Dr. Linda Chisache, as she takes the podium, take us through the next plenary session. You're most welcome indeed, Dr.
Thank you, JP, and thank you to all the organizers of this conference and those that have so far run us through the program since the beginning of the conference to where we are. We now move into a session on the elimination of vertical transmission of infections, and this comes just after the PS had spoken and told us how integration is how we have to move, and integrate we must. So The program for elimination of vertical infections is really integrated on the maternal and child health platform. And, all the implementation at the different level is really hinged on making sure that the maternal health, child health platform is really working well. For babies to be born free of these infections, it's really critical, as we were reminded by the newborn team, that all the care starts by giving the quality and right care to the mother. Ensuring that they attend antenatal care early so that they are able to be tested and they get all the services needed. Ensuring that they continue to attend all the 8 antenatal care visits. Ensuring safe delivery as well as proper postpartum care. Uganda is one of the 22 global plan countries which still show the highest burden of these infections, not only in the mothers and the adult population, but we still have the highest number of new infections, both for HIV, syphilis, hepatitis B, among children. Despite the many years of implementing PMTCT for HIV, new infections still remain above the 5% global elimination targets. We also know that over 95% of chronic hepatitis infections result from people who get infections prenatally. And these are more likely to progress into complicated liver issues, including cirrhosis and hepatocellular carcinoma. Syphilis is a very old disease that has been around for many years. I think in Buganda, it actually used to be referred to as obulwadde bw'abazira. It is a very easy to manage infection, especially in pregnant women. However, despite the fact that we know what to do, we have not really done it the way we should be doing it. It results in really devastating effects for the newborn, including neonatal death, prematurity, low birth weight, and other congenital issues. At the recently concluded Triple Elimination Conference in Africa, participants re-emphasized the importance of integration, strengthening the maternal and child health platform for delivery of all services that's on that platform. We were challenged as Africa to promote research and innovation so that we have African-led solutions to our problems. We were also challenged to advocate for manufacturing and diagnostics and medicines on the continent so that we don't have to wait for logistics coming from outside Africa. A call to action was signed by the ministers that resolved to renew the efforts to ensure that we all achieve elimination of these 3 infections. This session, therefore, is hinged on all that. We have very expert panelists at all levels, from academia to programmers, to civil society, to the district leadership, and to facility leadership. The session is going to start with a keynote address that will be given by Dr. Dithan Chiraga, and I will invite Dithan to come up. Dithan is the Executive Director of the Baylor Foundation. He's a public health physician with over 20 years of experience in technical leadership and management of complex health programs in developing countries, including post-conflict nations. His leadership and expertise include quality of care service delivery, public-private partnership for health sector development, and development of standards for public and private sector. Dr. Dithan will take us through the journey of triple elimination as a country. Something probably that should have been spoken by Ministry of Health, but it's also good to step aside and listen to what how other people are seeing the programming. This session was also sponsored by the Baylor team, and so we are very grateful to them. Our second panelist is Professor Philippa Musoke. Professor, you can also come up. She's an emeritus professor of pediatrics and child health at Makerere University and has been executive director and PI for the Makerere University and Johns Hopkins University research collaboration. She participated in most of the researches that actually led to the development of the WHO prevention of mother-to-child transmission guidelines. And her areas of interest include PMTCT, pediatric HIV, TB for remote limited settings. Our third panelist is Dr. Edward Bitarakwate, the country director for Elizabeth Glaser. Elizabeth Glaser was the very first partner for the prevention of mother-to-child transmission programming in Uganda, many years ago. Dr. Edward has been the country programs and technical director for the Elizabeth Glaser Pediatric AIDS Foundation. He is a pediatrician and public health specialist with over 20 years of practice, both clinical and community, and holds a master's degree in public health. Our fourth panelist is Sister Patience Oburu, the acting ADHO of Tororo district. Sister Oburu has also worked in the Actual Health Center and has recently taken up duties to manage as assistant DHO for Tororo. Our other panelist is Ms. Flavia Chomokama, the executive director of Nafofanu. Flavia is a gender equality activist and advocate. Flavia has lived with HIV since 1994 and is very, very passionate about women and girls' rights and ensuring that no more new infections happen in children. The last panelist is Sister Annette, coming from an implementer's angle. Sister Annette, you're welcome. So we shall immediately delve into the keynote address by Dr. Dithan. Dr. Dithan.
Thank you so much. Good afternoon, everyone. I had a slight panic over the break time. I was whispering to Professor Philippa Musoke when I wasn't seeing and she wasn't responding to my WhatsApp call, but I kind of got a bit of relief when I saw Professor Annette Nachimuli, and I knew she could have become a short notice substitute. But it's a pleasure joining everyone for this very critical session. First, I want to recognize and thank the organizers of this very, very successful conference for a job well done. So I'm going to share a few thoughts, highlights that will serve as the preamble for the panel discussion today. And I know it's the last day. Last days, people tend to be a little bit switched on and off. In many ways, you are speaking to half the audience, and the other half is also chatting with their drivers, making appointments for the departure. So hopefully we can keep this more interesting. Just sharing our own thoughts, observations as the Baylor Foundation Uganda in terms of the journey. And I wasn't taken through this session of moving. Yes. A little brief about the Baylor Foundation Uganda. We are proud and privileged to be a strong partner to the Ministry of Health to ensure that we deliver high-quality integrated services to the population in the country. And I remember Dr. Henry Mwebesa on the first day said that as Ugandans, we don't normally celebrate our successes. We tend to focus a lot on the gaps. But as the Bella Foundation Uganda, we are so proud of the great work that we've done over the last 20 years. If, for example, you visited some of the infrastructure that we've set up in many parts of the country, you'll be so impressed with the centers of excellence, the quality of the newborn facilities that we've put up in a number of district hospitals, health center force, most recently in Bolisa Hospital, Changwari, and Bwera Hospital. Really top-notch, highly functional centers that have been constructed. Also, we have a very comprehensive coverage across the country. Those that had rumors at the start of the year that we had been closed, I hate to disappoint you, we are still functional to a point where we've actually increased our coverage through the country. So we cover a lot of districts, working closely with the local governments, the districts, and really appreciate the support and the successes that we continue to enjoy. We've actually taken up a few programs that were terminated as a result of the cuts in the US government funding in the country. Yes, in terms of the burden for HIV, syphilis, and hepatitis B, those three maps speak to the burden of these three diseases that really affect us, affect a lot of mothers, pregnant women, and just three critical observations from those three maps. We see that there are regional variations in the burden of the three diseases, which calls for targeted interventions to address the disparities. But also we notice that there's a synergistic impact for the three diseases, which leads to worsened health outcomes. We see increases in disease transmission, heightened risk from mother-to-child transmission, but critically, the similarity that we see for the critical interventions necessary to prevent transmission for the three infections does favor an integrated approach while addressing these critical diseases. Now, in terms of Uganda's triple elimination journey, we've had a lot of lessons we've had to learn as we developed policies, as we changed the policies, the regimens that we provided for the last over 20 years. If you remember those that were around starting as early as 96, where we had the Petra study that investigated the short course ARV regimens to prevent mother-to-child HIV-1 transmission. Those studies then led to other studies. They led to pilots. We evolved into the option A at 14 weeks. Later on, we adopted the option B in pregnancy. We had phased rollout of these different policies. Eventually, we had the HIV and syphilis dual assay that was evaluated, found to be highly sensitive and specific. That was then piloted in a number of sites. It then adopted. Eventually, 2019 is where we had the Free to Shine triple elimination initiative that was launched. So we launched the hepatitis B virus PMT3 program at that time. In 2020, we launched the triple elimination plan. And then, obviously, 2022, we introduced hepatitis B birth dose that was added to routine immunization. So the process has involved a lot of science, has involved a lot of research, policy development, and it has also involved integrating different aspects of these programs, strengthening community approaches, so that we can move to the position that we are at this stage. When you look at, in terms of all ages, new HIV infection trends in Uganda over the last, from 2010 to 2024. You look at all ages, you look at vertical transmission, and the percentage contribution of vertical transmission to new HIV infections in the country. Deeper data analysis, and that has been shared in the course of this meeting. We see that first, we have 4 regions that contribute close to 50% of new HIV infections, especially for the 0 to 4 years. And these have been mentioned as South Buganda, North Buganda, Toro, and the Kole regions. But in terms of districts, we know that Kampala and Wakiso have the highest burden for HIV within the country. But also when you critically analyze this data, we see a bit of stagnation of vertical transmission, which we think is attributable to the synergistic impact of the triple burden. And that calls for it calls for proactive efforts to eliminate these 3 diseases. In terms of HIV vertical transmission trends, if you look at mother-to-child transmission rate at 6 weeks, we see a good positive decline in the transmission rates from as high as 11.8% in 2010 to the current 2.3 rate at 6 weeks. But also when you look at final transmission rates, including the breastfeeding period, as well as the vertical transmission rates, we see a slow decline, and that speaks to a lot of the efforts, a lot of the support, and a lot of the investments that have been geared towards this work. Now, when you look at progress over the past decade in dual and triple elimination when it comes to testing at ANC from 2016 to 2024, that graph shows you the trends. It shows you when testing for different diseases was introduced. The aim, of course, is to ensure that all the pregnant women who show up at ANC do receive timely and comprehensive testing services, including provider-initiated testing and counseling for HIV, for syphilis, as well as hepatitis B during the first trimester. But 2020 is when we really saw the introduction of hepatitis B virus testing at the majority of these ANC clinics. Previously, this service wasn't provided, and the trend has been going up, albeit maybe not optimally. Now, in terms of treatment, for the 3 infections at ANC, fairly similar trend. The idea is that we provide timely administration of appropriate treatment for the 3 diseases, for people having maternal syphilis, provide lifelong ARVs for pregnant and breastfeeding women living with HIV, as well as antiviral prophylaxis for pregnant women with hepatitis B virus. But still, you see 2020 is where we have the attempt to provide treatment at ANC for the 3 diseases with the introduction of hepatitis B treatment in 2020, starting at 21% of those that were tested and required that treatment, with a trend that is progressively also going up. A little bit on the policies and frameworks. We really appreciate the Ministry of Health that has developed a lot of these policies, the guidelines. The guidelines are really available. They are based on research. They are based on the learning. They are based on the science. We have a lot of job aids. And the critical thing for us, of course, is to translate a lot of these guidelines into actual practice. Then data science, yes, we've also used data science to inform a lot of the programming, and we've given different scenarios there where we looked at the PMTCT impact evaluation that was done in 2019, where we're able to look at mother-to-child transmission. We compared, for example, transmission rates between adolescent girls and young women, which we found to be much higher, those between 15 and 24 years, compared to 1.4% in the older age group. We compared transmission rates for those on ART and those not on ART, those suppressed, those not virally suppressed, those that attended ANC in first trimester compared to others in the third trimester. We looked at those on ART treatment, gender-based violence. We also looked at PMTC retention evaluation in 2020 that spoke to the most adopted interventions. For example, appointment tracking systems were highly adopted at 98%, birth cohort monitoring, but also that particular study examined the least adopted interventions. So we've used a lot of this data science to focus the resources, to focus the different interventions. I also wanted to speak to WHO's triple elimination framework. It is anchored on 3 strategic pillars. Pillar 1 looks at early ANC and continuity, gender-based violence, STI screening and management, male involvement. The second pillar looks at family planning, preconception care services. The third pillar looks at delivery under skilled care, labor management, protocols to reduce mother-to-child transmission. The fourth pillar is anchored on immunization, family health practices, as well as male involvement. And the goal is to achieve the elimination targets highlighted under each pillar. Call to action. As I conclude, I'll just read this verbatim. The first one, of course, is to ask the government to significantly increase bottom-line investments. We want to efficiently integrate healthcare service delivery, supply chain management systems, lab networks, and e-data systems across disease states, human resources for health absorption to Government of Uganda payroll. We want to fund the community extension workers model for integrated community-based services. We want to leverage laboratory capacity at lab hubs and point of care for integrated diagnostics. The second one, of course, is the government to significantly increase domestic and public financing for frontline investments. We want to leverage some of the resources available at district level, regional referral hospitals for HIV/AIDS, for example. If we can leverage a bit of that for triple elimination, mobilize additional resources through public-private partnerships. All together with Government of Uganda, renew our commitment to a generation free of HIV, syphilis, and hepatitis. Thank you all, and I want to hand over to the moderator.
Thank you very much, Dithan, for that presentation. You reminded us that we still have over 4,700 infections, new children coming out HIV positive. As we keep saying, the number seems a number until it affects you. I think that's a big number to be coming out every year after 25 years of HIV implementation. You showed us the regions which seem to have the highest burden, where to more emphasis needs to be put. You also reminded us that adolescent girls and young women, which is something that has run almost throughout this conference. Almost everything that is not working well is adolescent girls and young women. They are the ones with the highest maternal mortality. Now they are the ones with the highest number of infections, and they are the ones whose children are also coming out with a high number of new infections. You also reminded us about the presidential directive, the US presidential directive that came early this year, and how it shook not only Uganda, but all countries. We are very grateful that Baylor is still around and is still supporting implementation. And because of that, you also stressed the fact that the government of Uganda needs to step up and take charge of supporting programming across. So thank you, Dithan. So our first panelist is going to be Professor Philippa, and we want to hear from you. looking at how triple elimination has evolved over time, even with the persistent challenges which have been spoken to, especially the health system challenges, staffing and logistics, and also the fact that infections are still there. And being with academia that has really shaped evidence-based programming and policy, what is your assessment of academia involvement in shaping policy and implementation, not only for triple elimination, but for safe motherhood as a whole? And how can this be optimized for us to be able to achieve all the targets that we've talked about since the beginning of this meeting?
Hello. Thank you very much, Dr. Linda. I want to thank the organizers for asking me to join this panel. And thank you, Dr. Chiraga, for the excellent overview about elimination of mother-to-child transmission. I think, as most of you know, in 2000, we had the great landmark clinical trial of HivNet 012. And 25 years later, unfortunately, we're still having mother-to-child transmission. So in terms of academia, in response to your question, I think academia has been really at the root of trying to understand how we can prevent mother-to-child transmission of HIV and also triple elimination, not only for HIV, but also other infections and other diseases. Academia comes up with ideas and says, what is the research question? And how do we answer it in our population? So to just give an example, when we did the study HivNet 012, the West, or the US and France, had already done the study ACTG 076, and they were able to reduce mother-to-child transmission by 60%. But the intervention was not feasible for us in developing countries. So that's why the HivNet 012 study was done, because it was a single dose to the mother, single dose to the infant, mother at the onset of labor and delivery for the baby. And that intervention was feasible for the developing world. And as we saw, the whole world, the developing world, was able to implement that intervention. And WHO, it informed guidelines, national as well as international. So we've come a long way now. We do triple therapy, but that study is very important because it showed that you can actually conduct a study in a low resource setting, a relevant study that can be implemented globally. And I think that's what we have to learn from academia. We have to identify our main challenges, which are many, and try to say which are the priorities. Uganda actually has research priorities. How do we as academia focus not on the West decisions because of funding, but for us as Ugandans, academia, how do we ensure that we prioritize those issues, those challenges for our populations and the health of our mothers and our children? I also want to say that for those earlier researchers who were not involving the population, and now it's clear that the community needs to be involved right from the beginning, and that you need to ensure that they understand what the research is about and the benefit of the research. And so qualitative studies are now components of many of the clinical trials. So academia needs to also take that into account and say we're not just going to do our clinical trials, publish our papers, be promoted, but actually ensure that the community understands what we're doing and they can actually inform whether what we're doing will be scalable. And then lastly, because I know there are others, is that implementation science is the big thing now. We do clinical trials. They're great on paper. They're great in terms of publications, but the community is not able to be involved, and the Ministry of Health is not able to adapt. So we now need to, after our clinical trials, do implementation science so that we can actually implement the successful interventions and see what's preventing them from happening. Why is it in this day and age we still have 4,000 babies infected with HIV? I think it's unacceptable in Uganda. We did the initial trials, we did subsequent trials with triple therapy, and we know what to do. So the question is, how do we partner with the Ministry of Health and academia and do implementation science. Those sites that are not doing well, how do we partner with them to learn from the sites that are doing so well, like Baylor? Thank you very much.
Thank you, Professor Philippa. I think reminds me of the recent paper that I think was saying something about scientists getting out of publication and providing us with more solutions. With all the issues that we've discussed in these 4 days, we hope to have more information from the scientists for implementation in the next 1 year. So for Dr. Edward, for a long time, PMTCT services have been hinged on development partner support, both at national level and implementation. And the partners have been really instrumental in the achievements that the country has registered so far. What lessons can be drawn from these partnerships? And with the current changes in funding landscape, how best can the country position itself for sustainability, public leadership and ownership of the program, as well as accountability to enable the country to reach the WHO validation targets?
Good. If the PS hadn't spoken earlier, I thought I was going to breach a controversial subject. But that said, I'd like to congratulate NASMEC for a very successful 3-day conference. And Dr. Linda for sitting me alongside my teacher. One of the things we've learned from the partnerships is that being part of a global community of practice brings good things to any society. The partnerships brought funding, but they also brought knowledge, brought new practices. The so-called north to south collaboration and transfer of knowledge that was quickly followed by south to south. And within that south to south, we also learned that peer learning amongst ourselves in the health space contributed to the successes Dr. Dithan showed. We've been able to, on the side of HIV, on the side of maternal and child health indicators, we've seen that we've been able to arrest and reverse the negative trends. And it says a lot to what we can do together. So the partnerships have helped us achieve. If you look at the foundational elements that have brought us here, they're not going to go away. They're with us. It just needs a strong resolve for us to sustain the gains, pun unintended, but to also run that last mile. We've heard over the last few days that all the low-hanging fruit has been picked. And I think the question is why? We know what to do. When I look at a room full of people, I know that there is a resolve to run that last mile, but we need to understand what we need to do in order to cover that. So I think for me, the partnerships have been very beneficial. When I look at a lot of the program leaders at the Ministry of Health now, a lot of them have grown through these partnerships, and you see it in the quality of our strategies, our policies, and the quality of debate. We've learned how to do granular data analysis, how to use epidemiologic data to target our interventions. We've also learned how to determine workforce needs, to know who is needed where because of disease burden. We've learned advanced programming. We've learned how to implement these programs that are not only life-saving, but also contribute to human capital development. We know what it costs from the financing that has led us to where we are. To a point that we now know that business management, even in the public sector, is critical if we are to achieve the desired health outcomes in our populations, and the role of leadership. So I think the partnerships from the global level have brought us to where we are. But, they also have their downsides. Partnerships can lead to a dependency. If someone helps you for too long, one may forget that the primary responsibility to continue is with us. We've seen that the partnerships at times can be contentious. I need to balance what the global partnerships require with what the country needs. We've seen that. But we also saw that partnerships at times can be very fast-paced. We learned how to implement programs at scale and very fast. Too fast for us to adopt. Uganda is good at innovating, but very slow at institutionalizing what we've learned. Was that because of a very fast pace? Do we need to shift gears with a reduction in funding? If one wants to gain momentum, at times one needs to shift a car's gear from gear number 5 to gear number 3 to gain momentum. We need to be realistic with what we can achieve, but determine what is pivotal. What are those things you must critically look at? We've had decades of millions of dollars going into health information, but we are struggling to digitize. Why? So I think there are critical questions we need to ask, but most fundamentally, we've seen what the global partnerships can bring. But what about our local partnerships? The Ministry of Health is responsible for policy, strategy, standards. But it only manages, I think, less than 90% of health service delivery in this country. Where is the Ministry of Local Government here? It should be here. Do we know that the Ministry of Local Government has up to 13 measures of performance in the health sector? But we don't even reflect them in our annual health sector performance review. The point I'm making is that we now need to learn from those global partnerships to strengthen our internal local partnerships. We've been talking about performance management. How are we going to manage the performance of a workforce you don't own, you don't lead? It's the Ministry of Local Government, not Ministry of Health. How are we going to manage leakage of commodities when from the center there's a district internal audit function under internal auditor general? The point I'm making is that for us to run the last mile, we need to look internally and optimize those internal stakeholders. Ministry of Education and Sports, Ministry of Gender, Labor and Social Development, Ministry of Finance, Planning and Economic Development. But we have a Ministry of ICT. We have NITA Uganda, we have the UCC, and we are struggling to digitize. So in a nutshell, I think what we've learned in partnering with the global community, we can take and strengthen and deepen our partnerships at the multisectoral level, and of course with our communities. We are thinking integration, but there's no better example of integration in the health sector like EMTCT and Triple Elimination did. We embedded it within sexual and reproductive health from the day one. Thank you very much.
Thank you very much, Edward. He's brought back the importance of the multisectoral collaboration and partnership, and also taking advantage of what we have locally in order to implement better. For Sister Patience, sorry, maternal and child health services have seen many innovations in the past few years. Dr. JP was just talking about the local maternity and neonatal systems, and these have really led to a lot of improvement in the indicators, as we saw from the presentation of Dr. Mugahi. So how do we tap into these for triple elimination? Make sure that we ride along there and make sure that we are also able to hit our targets. Additionally, what is the role of the districts in ensuring that not only triple elimination, but other infections in general are seen as a responsibility and owned by the district health team in implementation, so that we can be able to implement quality services and also ensure sustainability?
Thank you. As district local government, we can tap into the integration of services like ANC and PNC care services, treatment and preventive services into the existing maternal and child health services, through HTS into routine outreaches, HTS incorporation into family planning outreaches. We can also empower district health teams through trainings, resource allocation for supervisions, and mentorship on peer-to-peer to bring on board the newly recruited health workers. As a district local government, we can also ensure commodity availability and security through empowering of the supply chain issues to prevent stockouts of diagnostics and commodities through redistribution within and outside the districts. Sustainability of financing amidst the dwindling donor funding can be addressed through private-public partnership and lobbying for additional funding and resources to support the triple elimination. Community engagement is yet another source to tap in from the different levels of community health workers, ranging from VHTs, community health workers, health assistants, to create awareness and demand generation at the local levels. Strengthening data system, data compilation, analysis, and utilization at the implementation levels to inform programming. We can also tap into accountability through the client satisfaction surveys, addressing the challenges of health workers and holding them accountable for their actions. There is yet a new program under MOH, the Self-Care Project, where the local governments can tap into the DMPA self-injection to improve the 4 prongs on prevention of unintended pregnancies, thereby improving the maternal outcomes. As district leaders, we can also do resource mobilization and tapping into the RDC's airtime for demand creation and awareness at the local levels. Task shifting can also be tapped in through the expansion of roles of health workers, ranging from VHTs, community health workers, and health inspectors, to create awareness to create awareness on HIV, syphilis, and hepatitis B. As local governments, we can also lobby through the ministry to have at least a functional fridge at every administrative unit, increasing access to immunization services as seen on the prevention of vaccine-preventable diseases, a case in this hepatitis B, ranging from the birth dose and the subsequent. Yes. As local governments, we can also tap into POC by clustering administrative units to the nearest point of care to access diagnostics and early diagnosis of HIV infection in the newborn. Prevention and treatment innovations like test and treat for HIV infection, single pill for HIV and the other single pill for hepatitis B treatment on diagnosis. Timely hepatitis B birth dose vaccination and continued with subsequent doses. Over to you.
Thank you, Sister Patience. Key that she has said is making sure we look at the client satisfaction survey, get the actions in there, and also accountability by the local the district, as well as resource mobilization. So for Sister Annette, earlier this year, we received the news of the stop work order from the United States President. And since then, Minister of Health has emphasized integration as the key modality to support continuity of services. We would like to hear from you as an implementer. How have you taken integration? What is happening at the facility level? What are the voices from the health workers and the patients as well?
Thank you very much, Doctor. I'm by the names of Annette Kabanyaka, working with Kabarole District, attached to Kijura Health Center 3. And since the year started, when the year started and the government and our donor aid was cut off, we learned to work as a team. There was good cooperation and coordination between providers, which enabled us to continue offering the service. Also the DHT and other leaders with some partners, it has also helped to continue offering the services to our clients because there has not been any stop of staff of offerings in service delivery. We've been having regular targeted review meetings whereby we do weekly data reviews, and for each facility, every week, each facility sends in their report, the EPMTCT report, whereby we see if there is any poor performance per week, we discuss the way forward and what to do as a team. That is being spearheaded by the ADHO, Kabarole District, which has worked. Because every week we present our data, we see where there are challenges and we come out with solutions. And since we are working as a team, with MCH, we are understaffed. But all providers and the facility, they are all knowledgeable in service provision. So we work together and mentor each other, and we've been able to continue offering services in an integrated way. Also, what I've also learned is on good leadership and planning. With good leadership, we've been able to ensure there is continuous service delivery even without the donor aid. Because for Kabale district, whenever they start, facility in charges sit with their departmental heads to plan for the little PHC that we get, and each department is represented. We present indicators and activities that we need to perform in that specific year in order to achieve, and that has helped us to continue offering services whereby we do outreach services, we do home visits, we do in-reach services in health center tools where they have no midwives, to ensure that all our clients receive services at all corners of the community. There is we try to minimize missed opportunities, because in some, like in Kabale district, in health center tools, there are no midwives, and sometimes the people offering services, they are not knowledgeable in PMTCT. At least the nearby health center 3 is in position to go to that health center 2 and offer a comprehensive care package to those clients. And in relation to integration of service, with MCH, we've been doing service integration. And whenever our clients come, we do offer a comprehensive care package. And that comprehensive care package includes the triple elimination of HIV, hepatitis, and syphilis, whereby all the services are being offered at the same entry point, that is MCH. We do the testing and the treatment at that same point. We even involve the male partners in order to totally eliminate transmission of mother to child of those diseases. And that has helped us to continuously keep the graph of elimination going down, because we've been able to even if when the donor aid pulled out, at least that we've been continuing to provide the service, and there has not been a big decline in achieving targets.
Thank you, Sister Annette.
Then the client's response. For clients, of course, they do appreciate the services we are offering. I know most of the clients, when they come, more especially mothers, they expect to get a variety of service. They come with different needs, and we make sure that we've given all the services needed. And for example, those MCS services, we have antenatal, postnatal, family planning, delivery, high-risk mother identification, treatment, and referral. We've been able to offer that, and clients are appreciating. And what has the challenges clients have faced is on the long waiting time, because you find it is the same provider giving all the comprehensive care package at the same entry point. But we've tried to talk to our clients to be patient. As long as you've explained everything to the clients, these patients have been very patient with us, because they know they will not be going back to home, then coming back to another clinic day, because we offer all services throughout the week. Whether the client comes on weekend or whenever, at any time the client walks in the facility, is able to receive whatever service they want. Though there is that long wait, because you have very many clients, and you have to do what? To look at each and every client. I think that's all for now. Thank you very much.
Thank you very much. She stresses use of data for planning and programming, teamwork, and leadership as a key driver of implementation. Thank you very much. And it's also good to hear that MCH has already been integrated, and so the rest of ministry can learn from the MCH platform on how to better implement integration of service delivery. So lastly, Flavia, the role of community and networks of people living with HIV has been documented over time, and their support to service delivery is undeniable. Community-led monitoring has been key in improving service quality for patients. In view of the funding challenges and the fact that these have mostly affected community, how do we avoid losing the gains in this era, and how do we implement community-led monitoring now when they choose, as we've heard, is the mainstay of integrated community service delivery at ministry at the moment? What remains the role of the CSOs and networks of people with high risk of the triple diseases, and how do they position themselves now in this prevailing environment?
Thank you very much, Dr. Linda, for inviting me and the entire organizing committee. I am Flavia Chomkama once again, and I work for the National Forum of People Living with HIV. But what is very paramount for me to say now is that the entire workshop has been talking about them, and today I'm representing the them you've been talking about. And I would like to say that the them has not sunk very well in our vocabulary. The them have not really been appreciated and recognized as mutual partners in ensuring that we have better health and ensure that we attain the health outcomes, the maternal and child health outcomes for this country. And just to say that we continue to ask them to continue to request to be on this table whenever conferences like these ones happen. And so we would like to implore, before I speak for them and give my story, that we continue to appreciate that the them we are talking about are the ones who are appreciating and receiving those services we are delivering, that those policies you are developing are to ensure that the them are able to access services to ensure that we have better health targets and also improve the livelihoods and lives of people in Uganda. So I am Flavia Chomkama, and I live with HIV, tested 1994. And at that time, the Prevention of Mother-to-Child Transmission project I was one of those very first one who was on PMTCT-A at that time. And I delivered a baby who is now 30 years. I had previously delivered others who are now deceased. The first three are deceased. The set of twins in 89, another one of 94 is also deceased. By that time, we didn't know anything much about HIV. And it is after the one of 93 who passed on 94, that in 95, I was in Mulago and we enrolled on the PMTCT program. So what I'm driving at is that at that time, in 1995, and I think those are the results that Dr. Executive Director Baylor was talking about, are those results of 96 that showed efficacy in ensuring that mothers, if given prevention of mother-to-child transmission treatment, they would be able to deliver healthy babies, but also save the lives of the mothers. So that said, communities are very, very important, and I am one of those communities and the recipients of care in this country. And we would like to share with every one of us the challenge of the recent shrinking funding. and we are caught in the middle of the shrinking funds and the integration web. And how has this happened? As communities, our role is to ensure that we mobilize our peers to come and demand and utilize services. And the second bit we do is to do treatment literacy. And for us as people who have been through PMTCT or EMTCT programming, we do know how we have been able to manage, and we are able to encourage our fellows, our fellow mothers, through the mentor mothers, the mentor fathers, the YAPs. I think these are names you already know. And we also ensure that we provide psychosocial support, particularly for those who have a face to lose, for those who are still worried about disclosing whether it is the HIV, the hepatitis, or syphilis status to their partners or spouses. But we also ensure that where we have provided psychosocial support and the communities are willing to uptake the services, we hold them by the hands and we take them to the facility, or we make a call to the VHT, we make a call to the midwife, and we say, we have this person, even if it is at 1 a.m., we pick people by their voices, by their worries, we pick them by the challenges they are facing and link them to services. And so that said, we would like to say that communities are doing a public health role, a public service role that is not paid for by government. That fortunately, the partner, the implementing partner, that donor has shown this government and us that it is a very worthwhile community to work with to ensure that we attain the gains. So when we refer, we don't stop there. People are initiated into care. And we deliberately and passionately, because we've been there, we encourage continued adherence to treatment, not even treatment, continued seeking support, counseling, and other social services to ensure that we have healthy mothers and we deliver healthy babies. And therefore, as a community of people who are affected and vulnerable and also providing that kind of support, we have, over the years, generated support groups. And these support groups are in our communities. Over the years, we have been overwhelmed as families, as support groups, and the donor has provided investment to ensure that we do that role and enhance and lighten the work of the health facility. And we have done it diligently. But over the last few years, we realized that we are now, we were doing mapping for the Ministry of Health Community Department 2 weeks ago. And when we went to the districts, we found that all those who had money, and the money has been cut, and they had been coming from Kampala to the districts, have vanished. Who is there? Our systems and structures, if I can use the one of people living with HIV, they are still there. At the district, they are working without resources. At the sub-county, they are working without resources. At the facility, in the community, they continue to do this work without even being paid. Even when a number of them could not be taken on as VHT, as CHOOS, they continue to facilitate and support utilization of services. So we are there, we are on ground. We are the one most static community system that exists in Uganda that has stood 30 years, and we need to build onto it. And I always say, let us integrate and not disintegrate. Or rather, let us not disintegrate to integrate. We already have a structure or structures of communities that already are known to work. How do we ensure that we consistently utilize these structures to build and integrate whatever else we would like to have? Because we didn't want to find a place where they are saying we don't want people living with HIV in this system because we have closed the health facilities for HIV and TB, and therefore we need new people. No. Integration is saying work and strengthen the system. So I'm glad to say that with the community, with the Prevention of Mother-Child Transmission Department, Prevention Department, we have been working closely. And we have ensured that whenever there is an opportunity for training, Dr. Linda calls us to say, who do you have in that district? Who can be on the training program? Who can spread the word? And we have done this diligently. But also we need to realize that communities are the day and night watchmen and women of prevention of mother to child. So we will always say what is working. We will always say where there is stockouts. And for instance, a week ago in Buyende, we have not had pediatric treatment, ARVs. So we liaise with ministries quickly, very fast, and we inform, and then they also liaise with the teams at the region to ensure that these are delivered. Right now, I have got a message from the north. There is talk out of third line, and I have already, in this room, connected with the pharmacy department of Ministry of Health, and I'm also going to liaise with JCRC to see, do you have the medication? Our structures are formidable, they are available, they are immobile, and they are here to stay. We are not refusing that the government cannot afford to meet our needs and our remuneration and allowances, but we continue to say that we are committed, continuously mobilize and ensure that the demand is there. Because for me, it's unacceptable that 30 years ago, I was on a project that was seen to be efficable, and we are still having 4,700 babies born to HIV. I delivered, my daughter is 27, my last born. She is HIV negative, but she's going to get HIV and deliver a baby. Why did I even belabor to be on that project? Why did we? But we shall continue to ask those questions, to highlight what is working, to highlight what is not working, with or without money. But we cannot do much unless we are facilitated. And that's why we are saying, in the current changes in the financing architecture for health, we are requesting and asking that the government takes on the role to facilitate community systems to do the work we've been doing where the donor has left. We shall continue to be on various committees. We have our own Lydia here, who is one of our chief whips in the civil society. She sits on the regional triple elimination committee. They continue to push the agenda there. We have Jackie Katana, who's on the World Bank Global Financing Facility. She's pushing for money to come to communities so that we do our role to monitor, to share what is working and what's not working, to ensure that the community systems that are grappling like government is, because for us, this hastened integration, we don't blame it on government. It's because it was a crisis. If somebody says, I'm going away, what do we do? And I will just end this with a story of the Ruero Triangle. When the guns were, when there was a lot of gunshots happening, a story is told of a mother who ran carrying something on the back thinking it is the child. When they reached the other end where there were no gunshots, they realized they had carried a dog. And so, of course, definitely the others who remained behind brought the baby, but in haste, we can always carry a dog and forget the baby. So we are saying, let us continue to be part of the integration framework on which we are. We are on the advisory committee, we are on task force, and we are partners in developing the programming. We are part of the mentorships, and our role is to continue to highlight the issue of human rights, the issue of preventing stockouts, the issue of stigma reduction and ensuring we provide person-centered services. We shall continue to say that the specs is small, that when I come to pick my medication, I'm not sick. I need to get my treatment and go, my refill and go, without lining up for the entire day. And we shall continue to document these stories so that we are able to use them and inform the integration processes, particularly the fact that we need to have more community engagement, because the facilities are there, the medicine is there, the doctors are there, even if they are limited. But what is going to help us attain our targets is to ensure that them you are talking about, us, are actually utilizing those services, and that adolescent young girls and young women who are of reproductive age, who are assert newly infected last year, get the support to live longer, but also deliver HIV, syphilis, hepatitis-free children. I thank you.
Thank you so much, Flavia. We commit as Ministry of Health to make sure that when we run, we shall not forget the baby. We shall carry the baby along with the whole. And we hear your cry, and we'll continue to engage you as much as possible. As we come to the end of the panel, I want to ask each of the panelists, from the discussion that we've had from the first day, when we talked about the mega improvements in the maternal health indicators, but with some still lagging behind, we have not yet achieved the targets for maternal mortality, and the biggest contribution is from adolescent girls and young women. We saw that postnatal care is still a challenge. Newborn care is also still a challenge, especially in the view of equipment. And now we've heard from the side of the infectious diseases that HIV is still a big burden. Syphilis, despite the fact that we know what to do, is also still a big burden. And the same thing with hepatitis B. Just one key takeaway to give to Ministry of Health, the organizers of the conference, that shouldn't be left out of the report as they compile. We shall start with Sister Annette and come, and then Dithan will, collate all that call to action and, give the final say for the session. One key takeaway, recommendation to Ministry of Health.
Thank you very much, Dr. Linda. I would like to request the Ministry of Health to look into the issue of funding. At least they should increase on the PHC fund, since we no longer have the donors to support in funding those EMTCT activities, so that we can continue conducting outreach, home visits, and in-reach services. And another thing, also, the ministry, we need to look at the issue of drug supply. Sometimes NMS supplies drugs with short expiry. For example, the last delivery, they brought Niverazpine syrup with remaining 1 month to expire. And I think there are some facilities right now with a stock out. They need to look into that. And on the issue of staffing, especially for MCH, we are understaffed. We need at least more recruitment of midwives to support in continuous provision of PMTCT services. Also, we've been working with VHTs and peers, like the peer mothers, the AGYW mentors. I would like if the government should continue supporting them. For those people, what I know, they need little motivation. And even with the cut-off of funds, those people have been continuing offering services, because those people were selected from the local setting. Up to now, they are still serving, but we need to retain them so that we continue offering services better. For those people that have been helping us in following up clients and community level, because they know all corners of the community, and these clients know them and they believe in them more than us. I wish if the government should also take up that and support the community health workers, like the peer mothers, the adolescent and young women mentors, the expert clients who have been supporting the facilities and the VHTs. Thank you very much.
Thank you, Sister Annette. The team tells me that Sister Annette has actually spoken to all their recommendations because she actually picked out more than one. We have quite a number of questions, but I don't think we have the time to speak to all of them. I think we, will answer them while we meet at lunchtime. But I'm going to ask Dr. Dithan to just wrap up our session, including, key takeaways from the session.
Thank you so much. First, to thank moderator Dr. Linda. I think she's done an excellent job, as well as the panelists. A lot has been said, but just to re-echo, there was a statement, a word that the PS repeated several times when she was speaking to us, when she said that we cannot go back. And I know she was making a lot of that reference to the TPAs, but it speaks to the great work that all of us have done over the last so many years, that amidst all these funding challenges, changing landscape, we cannot afford to go back. We have enough. We have the capacity, we have the science, we have the evidence, so we cannot afford to become complacent. We're on track for a number of these indicators to pretty much eradicate these diseases by 2030. So we cannot go back. For me, that's one of the critical messages. The second one and the last one is we also need to promote a lot of self-care. We are talking about decentralizing services further, which is a good thing, taking doctors, nurses, recruiting additional cadres, but also the population is rising at the same time. So we need to promote a lot of this self-care. We need to encourage the communities, the population to own their health. This week, we talked about this self-care, program, the app that was launched through which the population can access critical information, they can access referral information, they can call in to a provider if they need certain information. So we need to promote a lot of those innovations. Digitalization is also a critical one for us, and we need to embrace digitalization. Thank you so much.
Thank you so much to the panel. Please give them another round of applause. I want to hand over back to Dr. JP.
Ladies and gentlemen, another round of applause to that very, very wonderful panel. And I think at the end of the day, it's the learning that we go back with and how we apply that learning in our routine practice to cause change, so that when we come back again on the 21st, the 23rd of October 2026, we are reflecting and asking ourselves if what we discussed on the 22nd to 24th October 2025 has been implemented. It's a progressive journey, but from the energy I'm getting in the room, there is intention. And so we have to carry that intention forward. Now, allow me just to announce a few lost items. I have a driving license here for Emron Joseph. Emron Joseph, please. It will be very important you pick it from me. And there is, it looks like a data bank, please. And I've been also told someone lost, please. These are very important items. You don't have to leave in this place. Now, it's time for lunch. And I think the one exciting thing is that, and I want to thank Dr. Linda, you've really saved us some good time. This is the only day where we've gone for lunch on time, but thank you. After lunch, we will have parallel sessions. And the first parallel session will be a Safe Motherhood Forum on sexual and gender-based violence. That will be in the Renzori Hall here. The second parallel session will be Beyond Teenage Pregnancy, a holistic approach to adolescent health. That will be led by Maristops Uganda. The first one will be led by AMREF. And the second one will be led by Maristops Uganda. And that will be in Acacia Hall. Then the third parallel session for the day is Harnessing Multisectoral Engagement, which will be led by World Vision. And that will be in Ebony Hall. And the fourth parallel session will be on Making Quality Antenatal Care a Reality. And that will be in Mahogany Hall, and that will be led by UNICEF. And the fifth parallel session will be on Tackling Infections and Emerging Threats, and that will be led by the Ministry of Health. And that will be the Assistant Commissioner, Dr. Michael Mwanga. Now, once we've completed our parallel sessions, we expect to end all the parallel sessions not later than 1640, so that we return and close the 3 days. It's been really an amazing 3 days. The closing ceremony will start at exactly 1640. So the moderators of the respective sessions make sure that by 1640 we are done, because we are going for lunch quite timely. Now, once we've finished the closing ceremony, which will run until about 1730, we shall have a 30 minutes break for people to have a final tour of the stalls. And we shall start our awards. Now, we had over the years, we've received requests for members to attend the awards, and that request has been granted. So we shall have the awards here, and any person can come and witness the colleagues that have outperformed, all have contributed a little more than the rest of us. So that will start at exactly 6, and we shall be in this same hall. Our award ceremony will be in the same hall. So we shall convene here at exactly 6. We shall be rolling the awards ceremony. Now, after the awards ceremony, we have a small thank you, but it's basically representative. So we couldn't take everyone, but just representative. Of 300 of us, we will have a small thank you in the restaurant up there. 300, representative. So if you receive that small invitation to represent the rest at that small thank you, please, that will be going on in the restaurant up there. And without any further ado, allow me, before we break off, first, I want to appreciate the partners. They have been running on the screens, but I think it's very important as we draw towards the close. And we're going to re-echo this because we're in a very difficult year of the stop work order, but the partners got themselves together to ensure that we have over 1,000 people in this room. And I want to say thank you. I want to say thank you. Thank you, thank you, thank you. Our platinum sponsors, UNFPA, Save the Children, DAY3 Uganda. Our gold sponsor, IPAS Africa Alliance, Elmer Philanthropies, AMREF. Our silver sponsors, Self-Care, Japaigo, Clinton Health Access Initiative, UNICEF, PSI, the Global Financing Facility of the World Bank, Maristops, and World Vision. Our bronze sponsors, Stanbic Bank, DKT, Living Goods, the Embassy of Denmark, Bank of Uganda, and Seed Global Health. And those that contributed, PATH, the Macquarie University Centre of Excellence for Maternal and Child Health, Pathfinder, the UK Foreign Commonwealth and Development Office, and NAMA Wellness. And then our exhibitors, WHO, SEHAT, ADARA, Vitamin Angels, Faith for Family Health, VALUE, the Hash Technologies, SINAPI, Mother to Mother, Reproductive Health Uganda, LifeNet International, Nakasero Hospital, Kachet Pharmaceuticals, Nikosam. Without your incredible support, we wouldn't have been here, and they all deserve a round of applause, ladies and gentlemen. And now that we all know our next Safe Motherhood Conference, 21st to 23rd of October 2026, I'm sure the budgets would speak to that as well, isn't it, colleagues? Thank you very much indeed. Now, let's proceed for lunch. Please, Secretariat, let's open this door widely so that we don't have any challenge. Our delegates walking out. If you go through this door, you use the stairs. If you go through that door, you use the other staircase. I thank you very, very much indeed.
Every newborn deserves the best start to life. However, in Uganda, despite more births occurring in health facilities, many still don't survive past their first month of life. According to the Uganda Demographic and Health Survey, 22 newborns die every 1,000 live births. Each loss represents a family shattered, a system failing its most vulnerable citizens, and a reality we must confront. Despite national efforts, newborn deaths continue to account for nearly half of under 5 deaths in Uganda. To reduce the alarming rate of newborn deaths and improve care for 120,000 small and sick borns, a coalition of partnerships, namely Makerere University School of Public Health, Baylor Foundation Uganda, Adara Development Uganda, Zambia Hospital, and Ministry of Health, with support from Elmer Philanthropies, launched the Uganda Newborn Program in 2022.